we're down to 2 hours. We will get through this. Yeah.
I have a question. We talked a little bit about health information exchange. So when I think about it, like we do a lot of peer-to-peer exchanges because there's so many different type of EMR systems. How, and maybe this kind of speaks to the standardization, but like you gave an example of someone in Texas and you want your health records to follow you. How difficult or easy, or how does that work when someone can exchange information between two different types of EMRs?
So, great question. Again, it gets back to, it should be one of our goals to do that. So, Epic, as an example, allows the exchange of a patient record between an Epic installer, because they can control the electronic medical record as to how it's put in place. They define the agreement that WellSpan has an agreement to share information, and if Lee Memorial in Fort Myers signs that same agreement, then they, Epic, will help identify that patient and match the record. They don't store the information, they just say, this Rod Dykehouse is this Rod Dykehouse. So if you have a record, you can bring it and they can attach it over here. So in that case, the vendor, Epic, is trying to facilitate that exchange. Cerner's trying to do the same thing. And they're trying to do it directly, for the most part, but actually their focus is a Commonwealth, which was truly an exchange that they pulled other vendors in, Allscripts, some of the other ones to play a role in that. So they're trying to solve it at a different level. What we're trying to do is use that Commonwealth to connect to Epic. So the problem is we've been trying for years, and it's just that difficult to be able to do it. So I would expect in 2 years we'll be able to move a lot of information back and forth. But again, when we send them, won't necessarily drop into their electronic medical record because we do things differently. It'll be a tab, it'll be available to them. If they need it, they can open it. The emergency department physicians actually use that type of an exchange frequently, because a lot of the patients that come here, they're new here. But if they can get a little bit of information from somewhere else, that's a whole lot better than no information. So they'll dig a little bit deeper and look through a tab of information, kind of like a PDF. They'll do a little bit of that. So again, it depends on what the specialty is, what the needs are, how we can move in that direction. We actually connect to a couple hundred, to quote these numbers, but several hundred independent physicians in the community that have different records. They have the ability to identify themselves to our system, and our doctors can actually send them information directly into their EMR. So it is happening. It's just not happening the majority of the time. So there are ways to make it work. But that is the goal. So, good question. So before I go on though, are there other questions? Is this making sense? I can go deeper, I don't want to do that. I can fly high. You need any feedback from me? Is this the right level of information you need? Okay. All right. So we talked a little bit about malware and MedStar. I want to come back to that. Information technology and cybersecurity are kind of at a breaking point. These are old numbers, but it doesn't matter. It's actually picked up. It's worse today than it was last year, and so forth. So it is dramatic in terms of the increase in the attacks. These are things that are coming from other countries. They're coming from criminal enterprises, or they can be the teenager down the street who's just trying to figure out if she can do this. And these are all attacks that can make a difference in terms of vulnerabilities. Old data, all the data is a little dated, but you can see the magnitude of healthcare. As an industry, we continue to be challenged, and we have the largest percentage of breaches. It's changing a little bit. Even the federal government, the Office of Personnel Management, was hacked and breached. So no one is immune from this. And it's a question of, do they steal the data or do they just lock the data? I'm going to come back to the MedStar example. Here's a key metric, that if you have medical records, if you have a breach, on average, you spend over $500 per record stolen. So think about Target, think about Anthem, that lost tens, if not hundreds of millions of records. That's the magnitude that they're paying out. They're spending tens of millions and hundreds of millions of dollars to remediate the breach. So I'm just going to go through a few examples. Advocate is a major health system in the Chicago area. They did a review. Over a third of their providers in their offices don't use encryption. So you'll see some examples of PCs being stolen. So Target. My family and I, we were part of the original Target breach. We got new credit cards, we changed all the accounts. 2 weeks later, they gave us another card because they were hacked in that window of time twice. Like, thank you very much. So it's a problem. They sell this information. During that time, they basically went to sale. Today, it's not worth $20, it's worth about $1. Anybody can get credit card data all the time. And so it's just supply and demand in terms of what's out there, and you'll see this. Target had the ability in that breach. They actually got warnings from their cybersecurity team in their company. They didn't, because there were so many indicators of compromise, they just thought it was one more, and they ignored it. But they had the data. They could have stopped it if they had focused on it. eBay, when they lost all theirs, here's the brand damage. Half of the users said, I'm not going back to eBay because you can't trust them. Oh my gosh. Same with healthcare. We lose records. We have a lot of patients who will not be back here because they can't trust us. It's more and more, it's happening everywhere, but it is very painful. We talk about those who are retail. Healthcare is worse than retail because of the complexity, because we have physician offices that don't have a high standard. The healthcare industry is much bigger and broader, and you'll see we're much more of a target. We're worse off than they. Financial firms, JP Morgan Chase, no one is immune. I laugh. Why do they go after the banks? Because that's where the money is. Doesn't Dillinger say that? Why do you rob a bank? Because that's where the money is. So they're going to go where the data is. They're going to go where the dollars are. But stolen medical data is a hot commodity, much more so than a credit card. And why? Thoughts?
I was going to ask why.
So a credit card companies monitor this. They see a problem, they lock it. They send you a new number, no problem. They steal your medical data and your identity, you can't change that. There are families that their child becomes 18, they go to open up a credit card, they realize for the last 15 years someone has been acting as junior and has opened up all these accounts in the name of that child and that infant when they stole the information, because that identity continued to live and thrive, and they move forward. This is far more damaging than any financial data loss. Medical identity is the next great thing, because you can't change it. You can't change it. You can't just change the number in your social security number and become someone new and different. You can't change it. So this is worth a whole lot more money. You can see, so they're getting insurance, they're doing all these things, they become you. And this is where they say, it's fine dining. They talk about the dollars in terms of the value proposition, and it's happening everywhere. Here's a case where they stole a laptop, and all that information was not encrypted. On your PC, on your personal stuff, encrypt it, lock it down. If it's stolen, you go, oh, I lost my PC, but I didn't lose the data. This is what we do in healthcare. If we have our devices encrypted, the federal government won't fine us. If it's stolen and it's not encrypted, we'll be paying millions because we did not properly protect it. Cedars in August of 14 reported they lost a stolen laptop, at least 500 patients. Remember that, 500 patients in August. And every day there's more and more. Tampa General, they stole face sheets. So at registration, you come in, a face sheet on paper, they stole the paper. It doesn't have to be electronic. It was generated by the system, by the electronic system, but it wasn't. Every week, I get a list of all the breaches that have been reported. Every week, and the list can go, every day there's a couple, just in healthcare alone. And it just goes on and on and on. Oh! 6 weeks later, they say, it wasn't 500 patients. It was 33,000 patients that was on that laptop. Oops. Write a check. And you've now alienated not just the 33,000. Your other patients wonder, is my stuff secure with you at Cedars-Sinai? It's the brand damage in that regard. Ransomware, MedStar. This is a big issue. Before we go into the medical devices, what happened at MedStar Health System was one of the Petya virus, or one of these viruses that came in. They got into their system because they didn't patch their servers. They weren't current in their patches. Always run the Windows update or whatever so it's current in the patches. It locked and encrypted the data on their main systems and came back with pay us 10,000 or whatever dollars in Bitcoins and we'll give you the key code and you can keep on going. There's all kinds of conversation. They have never acknowledged that they actually paid, but if they did or not, it was never decrypted. They were shut down for days and they struggled for weeks to recover their systems. Their entire health system, I don't know, 5 or 6 hospitals in the Baltimore area, DC area, were down. The CIO at Hopkins, who I know personally, we've had conversations about it, it made an impact. They actually shut emergency departments down in the MedStar hospital. They could not deal with it, they could not accept patients. That was the magnitude of that ransomware. Went in, popped, locked everything down, shut them down. And they spent tens, if not hundreds of millions of dollars to recover. And in some ways, they still haven't. And it's been a couple years. Medical devices. How would you like, so to talk about how these things continue to grow in threats. Again, your credentials sell 10 to 20, again, the price keeps going down because there's more and more, but it's still 10 to 20 times what a credit card. That's 10 to 20 times more valuable than a credit card. Here's an issue. The Federal Food and Drug Administration is warning that medical devices are not properly secured. Not to make you worry, but you should worry. Infusion pumps. These manufacturers haven't built in any cybersecurity. It's your network. Right, it's yours. How you, not us. They haven't even designed cybersecurity into this stuff. I've been on Capitol Hill talking to agencies. We're going to meet with the FDA next week, my Chief Information Security Officer and I, to talk about how to make this happen. The federal government has not mandated medical device manufacturers to build cybersecurity protections into their devices. Really? Ultrasound machines, IV pumps, patient monitors, CT scans. Really? They have never mandated it in the manufacturers. And the manufacturers don't want it because they don't want the liability to say it's safe and there's a problem, and they don't want to put the money into the design and the production of this. It's too expensive. So they're fighting it, and so far the federal government has said, yeah, okay. We're like, you kidding? Every one of us. Horror stories. Think of if a rogue nation or a terrorist group wanted to affect 100,000, 200,000 Americans overnight. Figure out how to break into an IV pump, set a clock for 3 months out, that at that moment in time, everybody running the IV pump, it doubles the medication dose. What would that do to every patient, regardless of ethnicity, location, anything, would be harmed by doubling the medication delivery at that moment in time? It's not a hypothetical. There's people, patients that have broken into these things because they're not protected and have been able to manipulate these devices. That's the threat, and the manufacturers have not stood forward to fix that problem yet.
No, I was just wondering, my question was, is the threat at the manufacturing level or is it at a remote level? Like once the pump is infusing, can they remotely?
Yes. So this first came up with some of the, I think the St. Luke's pacemakers. They never built it in. And if someone actually, and they used a radio frequency that you or I could pick up. So it wasn't encrypted, it wasn't secure, and the threat was you could shut these things down. So they tell you not to go through the scanners in the airport if you have a pacemaker. Well, that might be the least of your worries. If someone can go in and grab that and change, that's the problem. They never built it in, and so they have to go back to the design. And our point to the federal government is, even if you said, well, right now the FDA has guidelines, but not requirements. for medical device manufacturers. And their point to us, I was on a panel in DC, they said, well, we gave them guidance. Why isn't that good enough? I said, it's guidance. They're going to opt in or out. They're going to opt out until you make them do this. That's the problem. And so even if they start to design it into their products, there's usually a multiple year, 3 to 5 years to actually design, build, test it, get FDA approval to go to market. And we don't swap these things out every day. These are very expensive. We just signed a $30 million deal to replace all our patient monitors and move into Philips.
Didn't get them yet.
I know. It's over 3 years because we couldn't afford to spend $10 million a year to replace them. So it's going to, and we're going to keep them for 10 years, 15 years again. So we're going to put in stuff that it doesn't have the cybersecurity protections in them today, and we're going to be running them for another 10 or 15 years. We're stuck. Because we can't afford to just go back and do it in another 2 years if they build it into it. That's the problem. So the manufacturers haven't done this. And this was a case where the FDA said, stop, this Hospira pump is flawed. And everybody took it off, had to shut it down. A mad scramble to get replacements in the market or to move to a different model. And that's the reality. So here's some of the classic. You want to be hooked up to a dialysis machine that was compromised? That's the threat. That's the reality. And that's why cybersecurity is such a big thing. And they keep talking about how, because they're not built and not secured by the manufacturer, and it's all on us to keep it secure. We've got 30,000 devices scattered around the institution. There's examples of patients hacking their own devices just because they thought it'd be fun. Well, I hope they make a mistake, but we'll be blamed. That's the problem. So again, in our network alone, and these are, we think we have about 35,000 devices. We don't have complete visibility into our network and all these things that keep coming and going. You can see the numbers. These are all the things we're doing to lock down our network as an example. If you fail and you breach, not only does your public punish you, as they should, the federal government will punish you. The Office of Civil Rights is the enforcement agency for HIPAA. What they did here, breach occurred when a physician employed by Columbia attempted to deactivate a personal computer server on the shared network containing Presbyterian patients' electronic PHI, protected health information. The improper deactivation resulted in it being accessible for the internet. Google searched it, everybody searched it. Good intent, take it off, deactivate it, get it, made a mistake. It's still live, wide open, boom. Office of Civil Rights comes in, part of their investigation. They didn't do what they needed to do. They fined Presbyterian $3 million and Columbia Hospital $1.5 million. Oh my gosh. So not only are you punished in the public eye, you have to do all the breach reporting, spend $500, $600 per patient to inform them. They're spending millions on that. The federal government comes in and just gives you one solid kick in the butt or worse. That was the biggest fine up to that point in time in terms of monetary penalties. Not only that, in healthcare, we have to report to the federal government when we have a breach. So we tell you, the government, and then they fine us when we tell you. Oh, this is neat. There aren't many other industries that are required to report at the level we are. Now, that's changing because in the public eye, if you don't tell soon enough, and you've seen that in the news recently, these companies have been hiding it. What was the latest? Tesla or Uber? They sat on it for a year. Really? We'll see what kind of damage that does to them in terms of trusting their information. In the Uber breach, it wasn't just our credit cards. It was the driver information. They got driver's license numbers and everything that the drivers had to apply for. They got all that information. That's a whole lot more than just a credit card number. That's almost like a medical identity. That's an employee ID. That's a lot. So what we have to report, and at that time there were 30 million in that year, if we have a breach affecting 500 more individuals, we have to tell the federal government we have a breach. And here was a snapshot of just everybody reporting, yeah, oh yeah. You can see it. You could go online and you can look and you can do a search and you can see the magnitude of the protected health information HIPAA breaches that are self-reported to the federal government. And you report, and the Office of Civil Rights can audit you at any point in time. And that's where they find Columbia Presbyterian 4.5, 4.8 million or whatever it was in total. Because they self-reported, they went in, said, was it kind of an accident, or you didn't do what you should have been doing? And they said, you didn't do what you should have been doing. There's a $3 million and a $1.5 million fine. So it doesn't even have to be us. Boston Medical Center, a vendor, posted the information. Oops. Do the patients care? We contracted with a vendor. We trusted them. Comes right back to Boston Medical Center. Doesn't matter that it was a transcription firm. You may pay directly or indirectly, but you're going to pay. Here's another one, contractor. So we have vendors coming in and out of our doors all the time. They're going in the ORs, they're helping doctors with new devices, talking about things, interviewing, following up, delivering things. Could be any one of them. Accidentally collect some information, walk out, and lose it. That would be on us. Again, back to the same slide. There's so much that we have, but there's so much we don't know. We have to be compliant with everything on our network that we know we own, and that which we don't control or know. No one will care. My job is to make certain the organization is secure and safe and operating at all times, regardless of what you bring in and you attach to the network. That's still on me. So we're required to report. If it's encrypted, we're good. Don't have to report, not going to be lost. The issue here is how tight do we make this? I can make this network secure, but you're not going to be able to get to it, Mikey, with research. Clinicians aren't. I can lock it down. But the issue is, you got to keep the business going. So what is that balance between locking it down, making it secure, and making it broadly available? That's a discussion we have all the time. So again, understanding authorization, authentication, encryption, how they're used, what they're intended for is important. Run through IT. So again, the industry is changing. And we have to understand it, we have to adapt to it, we have to accommodate it. You are all bringing your own device. You have Windows, iOS devices, you have Android, you have different versions, you have PCs, you have Macs, you have all this stuff. And we have to figure out how to accommodate it and make it secure, must be compliant. But I don't know what you have. If you come in with something that, and you drop it in our network, boom. Did any of you know that Penn State University College of Engineering had a major breach a couple years ago? So my chief information security officer, I brought him on board in October. His history was Texas Public Safety, so he was the security officer for the state police in Texas. Before that, he was with the National Nuclear Security Administration. So he was part of the Department of Defense cybersecurity team. He was here 45 days when the CIO at Penn State University got a knock on the door, and the FBI walked in and gave him a 900-page PDF. Said, you have a problem, and then left. And I sent my CISO, Chief Information Security Officer, up to the university because he didn't have one. He was between. He was recruiting. Go fix the problem, or just kind of assess the issue. That was in Thanksgiving when he got the notice. I didn't see my Chief Information Security Officer until June, July. Here's the magnitude of it. An advanced persistent threat, a foreign country, known as China, had dropped into the College of Engineering network, and this is 14, let me put this, 15. They had been present in that network since September of 2012. That's as far back as they could see. So they were there before then. They were probably extracting all of the research or anything they could get their hands on for that window of time. And my CISO worked with their team up there to basically, on May 15th of the following year, shut off the network, burn it. And they had rebuilt a brand new network in parallel, cleaned with new tools, new protections, and then all the information and data had to be scanned clean before they put it in the clean bucket, because this bucket was dirty. And there was no way they could get everything out of that. $10 million and 40,000 hours of work effort. They ended up with a clean network in the College of Engineering and the College of Liberal Arts. Those are two colleges on a campus of 26 colleges, and a university of 26 campuses. For anyone to think they're not elsewhere in the university, they're crazy. And that's the challenge we have. So this was a country. Why do research and try to develop things when you can steal it? I'm not saying we're clean. Everybody's probably doing the same thing to each other. But that's the magnitude of what this represents. And that's what cybersecurity is about, protecting the loss of information, or the malware, or the ransomware where they lock it and prevent you from continuing to do your job, where you have to pay a ransom to get it back, maybe. These are all the things. So those are the challenges, be compliant. Here's consumerism is what's driving this. How do you get to it wherever you want to be? So all of you have the need for it, and from home, all of these things, they're medical devices. Big question, patient portals. We've been implementing them, but why don't people use it? They like to do online banking, because they're very complex. Number one, they weren't fully funded. So we don't get paid to offer this. It's a demand, it's an expectation, and so forth. We spend a lot of money on a portal. And there's a lot of information we don't like to give the patient because they won't understand it. So that I say a little bit of this, really? It's their information, it's about them. They should ask. So we now release a lot of things directly. If you can imagine the medical staff furor when we said, when you dictate your notes, it will go right to the portal, they'll see them. No, I gotta review them first. Well, for what? You're gonna talk to the patient? Well, I won't be able to get to them in 3 weeks. Well, the patient should know. Change it. So we are actually releasing things trying to change patient and provider behavior to be more responsive to a test result, x-ray, things of that nature. If there's a mammogram and it's released and the physician hasn't had a conversation with the patient, I think that's a problem. Why would you withhold it until you have that call or that follow-up visit when it could be life or death important to that patient? So we're trying to change the behavior, but there were lots of concerns that they won't understand the information. It's kind of like, well, then have the conversation with them in a timely manner. So again, the technology is foreseeing behavior change in a lot of ways. Here's some other examples of patient engagement. I won't go through them in detail, but they had an app that lets people join them to stay well. Texting. How do you change behaviors in terms of what to eat and so forth? Social media. Let these things, let the power of the group, the family, the units, whatever, drive some of these things. It really is cool when this stuff works. And we can't control it. We shouldn't control it. We should release it. We should democratize this information. Let the patient decide. I'm saying this, and it's heretical for a lot of providers. No, we have to manage, we have to control. No. If we're trying to get the patients to engage in their own behavior and their own well-being and their own care, why should we be a barrier to that? That's part of the change that's happening in healthcare. We have a number of telehealth programs. Telestroke, where we have it the region at 16 hospitals. We don't own these. We have the ability. What does the program do? It helps identify the stroke in terms of can they deal with it locally, through drugs, through anticlot, whatever, or identify, oh my gosh, we're sending a Lifeline helicopter. That patient has to get over here because you can't deal with that in Tyrone. You can't deal, we can handle it. So it's helping us identify the patients that really need the high-end care and empower the local facilities to take care of the patients in a more effective manner locally. That's what the telestroke program is. Telederm, we have The wait list to get into the dermatology program is long. So we have primary care doctors that are taking a photo, sending it to our doctors. They're reading it offline at their convenience that evening, and they send back a note that says, yeah, no problem, this is, or yeah, we'll get them in. Those help deliver efficient, effective care in a location and a manner in that regard. ALS, Lou Gehrig's disease. This is one of the more powerful things. So an incredibly debilitating, fatal disease. Can go fast. The problem, these patients become completely debilitated in a fairly short period of time. For them to come in for a clinic visit requires an ambulance, incredible, oh my gosh, the caregivers. What this does is give them the equivalent of a tablet, an iPad, or Kindle or something like that. They can have a visit with the caregiver and the patient and the clinician without having to bundle them up, get them out, move them. And as the disease progresses, it's a great way to continue to have that clinical delivery remotely at the convenience of the patient. We don't get paid for it, but it certainly helps reduce the cost of healthcare for these patients and the convenience for the family incredibly. Telepsych, we have the ability in the emergency department. We can't always get quickly a psychiatrist down to the emergency department to do a consult. They can very quickly pull it up, have the conversation, interview the patient, and make a decision. If it's a psych admission, do they have to go to the psychiatric institute in that regard. So it's a way to make it happen in that regard. EICU. We have in the ICUs now, we are connected to Mercy Health System in St. Louis, Missouri. And they have kind of like a big screen. They have nurses who monitor hundreds of patients. They have intensivists that monitor a few. And the system actually looks for minute changes in the patient care or the patient condition in real time. And it'll suddenly flag from green to yellow. Something's happening. It'll then send the information for that patient in front of the physician, whoever the air traffic controller is there. And they'll they can hit a button, camera goes on, the microphone goes on in the ICU. They can begin to virtually real-time speak to the nurse, the physician, whoever is in the room, including the patient himself, herself, and they can take control. And if it goes to immediate red, they can hit a crash button, and all hell breaks loose while they respond to that. The system can monitor changes faster than the humans can see it and analyze it. And if you simply keep a patient from crashing, it can save, money-wise, tens of thousands of dollars for the care of the patient to get out of the ICU as opposed to staying there another week. Because the system is looking for directional changes in the patient. Virtual ICU, an incredible technology being used. We hope to extend this across the region, just like we have telestroke. Expensive to do, but very effective for those individuals that are crashing.
So one day I was floating to the 6th floor to MIMQ, and I was working with a patient, and then I hear a voice talking to me, and I turn around and there's a screen with a nurse telling me what's going on. And I'm like, we don't have that on the HVPCU. So is that what that is?
That is what it is.
Okay.
So the intent is to move this. We're building it out to all of the ICU intensivist rooms. There's actually the intent to move it to med-surg rooms, not for that level, but we pay for sitters to watch patients and so forth. We can do this virtually. And so instead of having one person per patient per room, we can have this air traffic control and the system monitor what's going on, and we can deliver better care real time at a much more cost-effective manner. And so it's all about telehealth. It's all about leveraging technology to improve care. And this is just some of the things we're doing. RFID, radio frequency identification. We know where you're at. I don't care if you're Walmart, who's tracking all kinds of devices. We can monitor and track stuff. If you're a nurse, you know that there are times you're looking for a bed or an X-ray machine or an IV pump and there's not one there. should be able to look at a screen and see all the IV pumps that are around. If they're in a room or tucked in a closet, being stashed and hoarded, that's the type of thing. C-arms, radiology equipment, the very expensive stuff that's mobile, we need to know where that is. And it doesn't mean people are using it inappropriately. It needs to be there when it's over here. We spend more time searching than not. We can track patients, talk to an individual at New York Presbyterian. They're building a new ambulatory tower in downtown New York. They're eventually going to have inpatient beds upstairs in the future. Security is a big issue in New York. They're actually, if they have a clinic appointment, like you're boarding a plane, at home you can print your boarding pass. You can print your badge that allows you access to go through a turnstile at security, and you go right in. If you don't have that ability or you forgot, you walk in and they have the Hertz rental people with a little printer on there, and basically they'll check your ID, they'll confirm, they'll print it out, hand it to you, and off you go, and you go through the turnstile. So they're actually helping people find their clinic. They're checking them in at the door, knowing that they're on their way to the clinic as part of registration. They're beginning the care and the customer service the minute they walk in the door, and they're extending it to the homes and all the way through. That's the type of thing that all of these things can track and can do in terms of moving forward. So, summary, we talked about barriers to adoption. These are all the challenges that we have. We are making progress, but it is about people. Patients refuse. If we as providers and users of the technology refuse, we're not going to get the value. And so the question earlier was, are we talking information technology or informatics? Informatics is largely the process and the people issues associated with technology. You can't do one without the other. Or you can, but you won't be effective. We need to focus more on the informatics, the people process, to deal with the resistance and change. We need to get more value from the information technology we're deploying. So healthcare itself, transformation, all of these issues. There's merger acquisitions in the industry. If you've had family members that have gone through cancer treatment and so forth, you know how horrific that can be as they're kind of guiding you or attempting to guide you through all of the treatment and the diagnosis. Oh my gosh. We don't put ourselves in the shoes of the patient to the extent we should. There are organizations that are doing it very, very well. We're trying to, we have a long way to go, but this is fragmented care. Everybody's dealing with my cardiology. I send them over here for the GI, I send them over here. We haven't figured out how to be effective and efficient to coordinate the care. We talk about Obamacare. I don't care where you stand on it. The perception was less choice. How do you save money? You don't give people this many options, you narrow it down. It was the only way to do it. Well, there's other things that failed, but with greater variation comes lower quality and more cost. We've got to figure out how to do this better. We have to. Personally, I'm in favor of more of a national health system, because if we don't have it, if people aren't insured, and they come to your emergency department, we're still paying for it. And there's no incentive for that patient to go home and deal with a primary care physician and be engaged in their health and take care of them. The health system in the country will pay for it one way or the other. I only ask people to think about what's the most effective way to deal with staying out of a hospital and improving wellness. That's the real goal. And all of our incentives are messed up. Doesn't matter, Obamacare, all of our incentives are messed up, and I'm going to come back to that. So we talk about these things in terms of kind of the pyramid of healthcare reform. At the end, it's about these consumer-driven health plans. If you were worried about what you're going to pay for the healthcare, for the diagnosis and treatment, you're going to ask questions. We need to ask questions. Don't just go blindly into that MRI scanner and end up with a $3,000 bill. This is about managing for value, keeping people out, keeping people well and out of the hospital. That is the ultimate goal as you go through this. Talk about how our current model is unsustainable as we have it today. This was 2011, hasn't changed much. This is the Medicare High Trust Fund. The Medicare High Trust Fund is expected to pay out more in hospital benefits and other expenditures than it receives in income. And at that time, it would be exhausted in 2024, 5 years earlier than previously estimated. It doesn't matter the date. It's getting shorter and shorter. We're not investing in either Medicare or Social Security to make them sustainable. The demographics are going to get us. When we had 10 workers for every retiree, it might have worked. Well, that pyramid's getting, we don't have as many workers supporting all of the baby boomers that are going to retire. It's not sustainable, and we have not adjusted this to make it work. So one of the issues we're all faced with is how, I don't care about the tax cuts and so forth, think forward, plan forward, how will we sustain these programs? If they're the right thing for the population, we have to figure it out. Here's a comparison internationally. Again, oh wait, but it doesn't matter, it's continued. Average spending healthcare in the US, 8,000 versus Denmark or Norway, Switzerland, 5,000, and everybody less. Total expenditures as a percent of gross domestic product. We're now at 18%, I think the current number is. So we've continued to go up. Look at that gap. The others were at 8, 10%. We're double that in terms of what we spend in healthcare. Is that sustainable as a country? No. So how do we deal with it? This was the most amazing stat I had seen. That's why I share it. We're consistent with other countries until the magic age of 57, 58. As a country, as a culture, we do not accept death as an extension and a natural progression of life. We spend the majority of our dollars in healthcare in the last 2 to 3 months of life. We don't let go. And it's usually not for the patient. It's usually for the coping of the family. And as providers, we teach them in medical school everything you can do to extend and sustain life. I was telling my father-in-law is 91. He's at home in home hospice. They're paying out of pocket for round-the-clock nursing care because they will not get coverage for it, and they don't want to go to nursing home. We got him up to the table for Thanksgiving. He's 190 pounds. Oh my gosh, I can't, we can't. It's an incredible burden on the family. And we ran there back in September thinking he was going to die. Well, he perked up when we all showed up, and he's been able to keep it going. But, oh my gosh, I love the conversations I have with him. I don't think because of the pain meds he's on, he's certainly not retaining the conversation, but it's we don't let go. It's a cultural issue for our country. Other countries accept death as part of life. That is the most revealing stat of all the ones that I've seen. It's not sustainable. So we talk about the healthcare system and reimbursement changes. These were the triple aims, the Institute of Medicine triple aims: quality care, affordable access to care. This is what we're chasing. And our challenge again here on this campus is, even though we want to keep people out of the hospital, there is a need for inpatient care in our community. We're at capacity all the time. Children's, we're at capacity. We have to figure out a way to get them out or keep them out. So population health is about managing and moving from being paid to do things to patients on an episodic basis to managing a population and not being paid to do it, but figuring out how to keep them well. How can you keep them home? So traditionally, fee for service, when they show up, we do things, we get paid for what we do to them. In this view, accountable care, population health, we need to go, that person, okay, those 5-10% of the population, if we get them to take care of their chronic disease better, we're going to do less, we're going to keep them out of the hospital, and they will be healthier, and we will spend far less as a population. That is the goal. But which 5 or 10% are they? That's what we're talking about, data and analytics. So we need technology to identify from these populations who they are and then give that information to the clinician so they can keep them out of the hospital. They can change the behavior of the patient. They can eat different. They can stop smoking. They can do things different to stay well. Change is hard. And my uncle died of emphysema, and he smoked almost to the end. It's like, really? Uncle Dave? Yeah, haven't figured it out yet. That's killing him. He stopped when he had to, and he survived a few years beyond that. Change is really hard. We have to focus in healthcare to manage the population towards wellness, which is about personal behavior. We talk about clinical integration of how do we increase the collaboration and interdependence among caregivers to deliver better quality and reduce costs. That's what this is about. It's all of these things we talk about population health, but it's the technology that can help identify the opportunity. It's the technology that can put information back to the provider to say, when Ron Dykos comes in talking about smoking, talking about his diabetes, his blood sugars, help him change. That's what this is all about. If we can reduce variation in delivery of care, we can improve quality, then we'll spend less. Right now, we kind of react to everybody doing what they want to do and what they've been doing. We haven't changed any behaviors. Population health is about changing behaviors. So again, where we can identify it, get the right care to them, keep them out of the high expense acute, and then manage it. It's all about that. That's what population health is. There's a lot of things wrapped into population health, but at the end of the day, it's doing that. Here's why, an example of why it's hard. So for a diabetes patient, here's all the different things they need to look for. There's these different quality metrics, HEDIS, all of these things they report on. So you say to a primary care doctor, manage your diabetic patients better. Do these things. That's hard for a primary care doctor to look at a patient and do all these things. Now, those same primary care doctors don't have just diabetic patients, they have all of these chronic patients. Wow. They're just seeing the patients as they come in the door. They don't have the ability to stand back and look at their population and say, you and you and you, we're going to put you in this, we're going to manage, we're going to do things, where a nurse is going to call you, we're going to do. That's what the information technology has the opportunity to make a difference. If we can help identify it, get it back to make it actionable, that's where we can make a difference. Just as I said earlier, the challenges we have is like connecting all of the person, the clinic, the long-term care, all of these different providers across this very broken system with different data and different, and to be able, and again, it's not the clinical data that's normalized, it's just the billing data. That doesn't give a clinician anything to make it actionable. We need to have the analytics that can make it, identify it, and then we have to improve the patient engagement. If the patient doesn't want to improve their health, there's not a whole lot we can do about it. So how do we change the behaviors? How do we make it real for them? So healthcare transformation, these are all the things that we have to do, and technology can support that. It's about moving from that fee-for-service episodic to the population. It's connecting all these things. It's the analytics. That's where information technology can make a difference for all of us. And we're still, unfortunately, focused on continuing some of the same as opposed to changing these things. There's some real cool things we're working on to try to get in front of this, but we have a bit of a ways to go. The last thing I want to talk about real quick is genomics. Everybody says, genomics will solve everything. We'll know that you have a tendency for diabetes, you have a tendency for this, and we'll get in front of it, we'll make it all happen, we'll fix that. Not so fast. So as common as we are, this is classic, we can identify things to make medicine more personalized. I'm going to give you some examples. So we have a lot of this in place today. We have the databases, we have clinical, we can mash them together and look for opportunities that says this genomic profile will lead to the probability of a higher Parkinson's or diabetes or whatever. Here's a great example. I don't know if any of you are familiar with this at all. Stole this from Dr. Broach, who's the medical director of the Institute of Personalized Medicine here. So this drug inhibits a cancer called BRAF. It's found in malignant melanoma. Here's the trick. This drug works in 60% of the patients who have this mutation. In those patients, it will reduce the tumor in a significant proportion. Very cool. Well, give me that. Well, here's the issue. The other 40%, it will make it grow faster. Who in this room wants to take this drug? 60% you win, 40% you lose.
No.
And you lose faster. Wow. So the drugs can do it. The issue is, how do you identify it? If we can identify the genetic disposition of a patient, we can hit the 40% and the 60% almost 100% of the time. We'll know if we give it to you, you're in the right category at a very high percentage. That's what personalized medicine is. And so what we're doing is trying to link the patient's treatment. We're collecting samples. We're doing the analysis. We feed that information back to treatment to improve treatment protocols. This is the glory of an academic medical center. If we can do all this well, we can make a difference in the patients that come through the door. That's what this is all about. It's tracking, because you can't predict it. You have to see it. And unfortunately, there's a lot of patients that died who were in the 60% or the 40%, and we didn't or didn't. We wouldn't know otherwise. And then with that genetic link, we can make it happen. So we're spending time in the Institute of Personalized Medicine over here to be able to make a difference. Here's a great example. These are the Diane quintuplets. I think they were in Canada. They were identical, which means genetically, they were identical. Well, they should die of the same thing at the same time, everything. Nah. Phenotype is the presence of disease. Go back. Genotype is the risk of disease. Your genetics don't define it. Disease concordance among identical siblings is weak. She died of a seizure, she died of cancer, a blood clot in her brain. And they were genetically identical. Phenotype is the observance of disease. So it helps. It doesn't define if you're genetically. But we can link genetics to effective medicine, like I said. If you're in the right 60%, we'll give you that drug, and you should be longer life, maybe cured. The things that we're seeing now in terms of genetic treatments are pretty extraordinary. Patients that would die are surviving or getting 5 years or 10 years of quality of life. We do a lot of clinical studies here, and we encourage people to sign up. You can go online to this website. You can look at all these. We'd encourage you and family to look for studies that you can participate in as a normal volunteer for comparative purposes. These are all things we look for. So the role of technology, information technology, the health system, the education, research, clinical, community, everything we do is completely dependent upon information technology. Hopefully I've impressed it on you tonight. It's the foundational connectivity. It's the applications, it's the data, it's the reuse, it's the analytics, it's everything. And we have only scratched the surface of what we should be doing, whether it be connecting electronic medical records for a patient when you travel the country, whether it's identifying genetics to more focus your treatment and to define and predict. It's all that. And as we continue to change technology and healthcare broadly, information technology has to be very much there. So hopefully, I made the case that healthcare IT is unique. We have a lot of the same basic things as Amazon and everybody else running a business, but the things that we're challenged with are unique in a lot of ways. IT is changing. We have to be aware of that. We have to support that. We have to incorporate that in what we're doing. And then as healthcare continues to change, we have to marry all that and be proactive and empower the organization. So like I said, our vision, we haven't documented, It will be something like we empower the enterprise. We empower the mission. We empower the people, the patient, the families. We empower wellness. That's got to be what our goal is. So again, everything we do in the health system for what we do is very dependent upon IT. We can't be a barrier to the business. We need to move to empower the business. Questions? Make sense?
I have a question about genomics. So when you talk about genomic data, is that just in reference to, like your example, it was talking about medication after somebody was diagnosed, but does it also look at preventative measures, so like BRCA genes, carriers for like CF, Tay-Sachs, that type of data as well?
There are, every day, every week, there's new genes that are identified to either identify a tendency or absolute. A couple years ago, there were already 50 genetic things that they could look for that could define things. There's a lot of, for cardiovascular birth defects and so forth, they can identify these things in terms of the infant, the neonate and that type of thing. Every day, that number is up to, I'm guessing, 150. And that's what they're doing. They're trying to identify the genetic link that leads to a treatment outcome or an outcome in that regard. That's what it's all about. The more we understand in terms of the genome, in terms of tendencies, probability, and effectiveness, that's how they can get to precision medicine. And it's forever. But 5 years ago, there was almost none. Now it's just exploding in terms of identifying these things. So, what else?
So what are the disadvantages of the technology in medicine regarding the patient safety?
So I'll give my opinion. I think we depend already too much on technology to make up for the lack of critical thinking among providers and clinicians. Looking at the nurse, but it's amazing. The students coming in, they just order stuff, and they want all of that to kind of come on. Boom. Well, if that's the case, we don't need you. We don't need the doctor. We don't need. It really is. You go to other countries that don't have the technology. They do better primary care and preventive care and wellness care than we do because we're so dependent now on the technology. I think that's something that we have to begin to fix, and I think it's been identified in the schools of medicine that they have to be able to put the soft skills back in. It was 15 years ago, one of the chief medical officers complained that the students coming out today don't know how to do a history and physical. They just order stuff. And I think those are some of the things we're losing. And again, I don't have an answer, but I think we depend on this, the Star Trek. Just wave that electronic monitor over the patient and tells you what to do. It's still an art, and there's a whole lot of people issues that really drive healthcare. I can say that about my father-in-law. It's the conversation we have that gets him excited to stick around a little bit longer and that type of thing. And technology isn't going to do a thing. So for me, I think that's part of it. How do we get the art back in and don't just depend on the technology and the science of it? This can help, but it's got to be that balance. So that's my opinion.
A lot of pharmacists say that too,
Pardon?
even about themselves. Because a lot of times they'll be looking at prescriptions and the computer tells them whether or not there's interactions with medications they're already taking, and it's like they're just robots. When they go to give a consultation, they're told what to tell the patient off of the screen. We hear that a lot too.
When we do make patient safety, we make mistakes. More often than not, people say, well, the system told me to do it. Well, that should be guidance. That should be you as a clinician have the ability to override. We expect you to do that. And so part of that, we're trying to build that back in terms of safety and a safe zone. We want clinicians in the room to stand forward and say to the surgeon, no, the left leg, not the right leg. Historically, there's been such control and fear of the physician, just like the airline pilots. Think about where the airline industry is. There's checklists, there's requirements to challenge. They have to be accountable for that. To some extent, an airline pilot is more accountable because if she makes a mistake, they're going to die in a plane crash. Here, they may have damaged the patient maimed, killed a patient in that regard, like they're not gonna die. Other issues with it. Again, I think we have to figure out how to use technology, but use it effectively and be critical in its use and not override our critical thinking. I think that's right now one of the great challenges. The population health, to identify the patients and the opportunity in all this data, that's where the technology can help. But I think we're depending on it too much right now in some ways. Don't tell anybody I said that, because that's my job.
Yeah, that's your job.
Any other question, comment?
So, yeah, I have a question. So how information technology can help in care coordination? Like the providers, most of the time they are so reluctant to, coordinate care, like they don't see anything out of their field. So how can information technology help here?
And
Though the things are documented there, the providers are reluctant to see them.
unfortunately, the way we're doing it is we're plugging, so you're right, everybody's looking at their silo, a cardiologist here and so forth. We're actually using nurses and others, care team coordinators, to bridge that gap. So we're not fixing their perspective, we're working around them to help coordinate the care. So we're trying to improve our connectivity to skilled nursing facilities, to home health care agencies. We can use technology to make the arrangements or have the contact to know that there's capacity there, but it's not changing the behaviors yet of the individual providers. They're still very specialized in their own little niche. And that's part of my criticism. I think we haven't fixed the problem. We're putting Band-Aids on the problem. But yeah, we have care teams that are trying to coordinate all of that. So, good question.
Is there anything in the system that prevents the duplication of the service, like duplication of this test or we have studied a case in which the physicians ordered the CT for a patient 59 times, I think. So is there
Well, that's easy. That's the patient that's glowing walking down the street, from too much radiation. That is what the electronic medical record is intended to do. But if they don't look and they just automatically order, that's part of the problem we have. And so we do try to build in some of those rules that challenge. And there's new, the American College of Radiology has some new standards for ordering. Because now the concern is if you have a lot of CT scans, you reach your lifetime limit of radiation. You can get cancer from too many X-rays. And so there's new algorithms we're putting in the electronic medical record that if you're going to order an X-ray, it's going to go in and calculate, and it's going to try to look at, do you really need this or not? But at the end of the day, it's still dependent upon the provider to do that. If a patient moves and goes to different emergency departments at different times, that's where the lack of coordination and awareness gets in the way. And we still have patients that are drug seeking, so they go to an ED, an ED, and an ED for the opioid or whatever, and they don't care what you do to them in terms of an X-ray for that pain in his back and so forth. And if we're not talking, then that can happen. And we're doing a better job of that. So the emergency departments now have the ability to see that Rob Dykehouse was there and there and there. And you can have a conversation with them and move them on. So again, it's coordination of care within an organization, it's coordination of care between organizations. It's all focused on better outcomes, better wellness, keeping people out of the hospital. So we're making progress, but
Trivia question. What is the lifetime amount of radiation one should get?
I can't speak to the actual, but just like you, it's cumulative. And so each X-ray, they know what that approximate average is. So they'll go back and they'll calculate how much you have. And part of the problem is CT scans, they're doing 128 slices. So they're taking 128 pictures of you. That's a lot of radiation going into your body to create that CT scan. That's what they're trying to figure out is, no. There's a lifetime limit. If you cross that, you have an increased chance of cancer. So while you're trying to diagnose things, you're actually inflicting potential pain and harming the patient.
So isn't that now more like for breast cancer, for example, like prevention and doing those even 3D now also.
Right.
So
that's all. So I say that the new scanners, the amount of radiation that they use is far less than they did just 5 and 10 years ago. So they continue to reduce the amount required to get an image. But if you're a patient that's had lots of back surgeries and so forth, they just, again, a cumulative total.
Yeah, you were talking about when healthcare providers started implementing EMRs, and they're encouraged with HITECH Act and incentivized and all that. If standardization is such an important part of this framework, was there any standardization requirements when all of these incentives were being rolled out?
So that's one of the flaws in our country. We believe in the individual companies and the capitalism, capital driven mode. And so the providers don't want to be all the same, because then they become replaceable. They become a commodity. And so each one of them, if Cerner or Epic said, we're going to work together to become one, you wouldn't need 2 companies, you'd have one. And that's part of the challenge we have. In New Zealand, one of the companies that I dealt with when it was UCLA and here is Orion. And talking to them, they had in New Zealand, a much smaller country, 5 million people or something like that. They had 1,500 different EMR vendors that were delivering electronic medical records to all of these doctors. Well, the government is a single payer, and so there isn't the need for variation. They all collapsed to about a handful. There was no advantage in terms of being a little bit different or a different color, or this is pastels versus royal color. It just blended into, and now there's just a handful of providers that deliver all the electronic medical records across that country. And that's the issue. So here, we allow people to make their own decision and do it a little bit different, and we pay them for the procedures, run through that. And so there was no, in our politics, no ability, no intent to identify all of us once as a patient identifier, or to say there's one answer to everything. So
It just seems like
it's the politics.
decades down the road, well, even just right now, coordination, integration, exchange, all seem like hot topics. If that's something that is really desired, it just seems like that is contrary to that, I guess, across organizations.
It's all our culture. So Canada, and I'm going to give some stats that were correct, I don't know if they still are. All the taxes in Canada, about 40% of the taxes collected go to the healthcare system. And so when you go to these other countries, my daughter actually works for Epic in Helsinki, Finland. And in Helsinki, in Finland, it's a single payer, the government, and they're installing the electronic medical record. But they also have the behavioral health, and they have the social work. And they went, why do we have 3 different systems? Epic is writing a system to do social work, behavioral health, and electronic, because the patients are the same and the government pays for them. And what they're doing is to keep privacy issues separate. So they break the glass when they must, but if you're in the different programs, you don't necessarily see across. It's one payer. In 90% of the countries in the world have one payer. If they pay, that would be the government. We have 64 different variations, insurance companies requiring Medicare UB92 standards. So it's what we do and how we do it. And it's worked for us, but it's very expensive. And until we get over the hump and we say it's too expensive and we're going to change our behavior as a country, we're going to keep doing this. Okay. Very good, thank you. Great group. Appreciate all the questions and everything.